So guys, welcome back to the session 6 of the FMGE revision. This is your Dr. Patil, the faculty for medicine at PW, and in this session we will be taking a quick look at important nephrology topics. Okay, now what are the important topics? Well, there are 4 important topics. Number 1, the basics or approach to a renal disorder. Number 2, acute kidney injury. In the acute kidney injury, how to differentiate between the pre-renal acute kidney injury and the intrinsic renal acute kidney injury, to be more precise, the acute tubular necrosis, differentiating between AKI and ATM. That's the second important topic. Number 3, you should know the definition and diagnostic criteria and the staging of acute kidney injuries. That's going to be an important criteria. And chronic kidney disease will be the third important topic. Now, in the chronic kidney disease, mostly it is about the staging of CKD, and number 2, complications of CKD. Okay. The fourth important topic will be glomerular diseases, which I will leave it to the pathology faculty to address the glomerular diseases. At the end of the pathology, if you still have some clinical doubts on the glomerular diseases, you can definitely approach me. We can have a one-on-one session, or maybe I can address them through some additional small YouTube bites. Okay. So let me start now with the basic understanding, right? Because nowadays questions from any system are coming in terms of clinical questions. We need to identify the disease first from the clinical story, and only then we will be able to answer the question, right? So symptomatic approach is going to be very important, right? Even if you're fresh with the nephrology or you're good with the nephrology, the next 10 minutes are going to be important for us. Now, first of all, what is kidney? Kidney is nothing but tissue that holds, not the neurons, nephrons, and the connective tissue that holds the nephrons together. Okay. Nephron also has parts, right? What are the parts of nephron? It has a glomerulus. Glomerulus primarily has a afferent blood vessel and a efferent blood vessel. So blood comes into the glomerulus through the afferent blood vessel unfiltered, then passes through the glomerulus, and that leads to the glomerular filtration, right? The remainder of the blood goes out after the filtration process through the efferent blood vessel, and whatever that is filtered through the glomerulus, this is what we call as Bowman's capsule, right? That will travel through the first proximal convoluted tubule, then loop of Henle, and then the distal convoluted tubule to collecting ducts. Eventually it will be thrown out as urine. Now we have to remember here that the filtration is drawn by the intraglomerular pressure, right? The pressure inside the glomerulus should be high for the filtration to happen. If the pressure inside the glomerulus is low, then filtration does not happen. In what condition the pressure inside the glomerulus can be low? When the flow from the afferent blood vessel is low. That when does that happen? When the circulating blood volume is low or patient is in hypotension. This is what we call as a pre-renal acute kidney injury. Okay. Now once the filtration has happened, selectively the substances that body needs will be reabsorbed at different locations, and the substances that body does not need, they will not be reabsorbed, they will be excreted in urine. So the reabsorption is function of your renal tubules, your PCT, loop of Henle, and DCT, right? Their main function is reabsorption of the substances that body needs. So if there is a damage to these tubules, the reabsorption is affected. Clear? Okay. Now having understood that basic, we should also be able to recognize the site of damage based on the symptoms. Like, how do I recognize if the problem is in the glomerulus? How do I recognize if the problem is in the tubules, right? How do I recognize whether the problem is in the connective tissue that is holding the nephrons together, right? So let us make an understanding of the symptoms. What are the symptoms of kidney disease? Number 1, if there is a damage to kidneys, obviously kidneys main function is urine output, so there will be alteration in urine output. Okay, so what is the normal urine output? Normal urine output is around 0.5 ml per kg per hour. That is a normal urine output, 0.5 ml per kg per hour, right? Now if the urine output increases more than this, right? If the urine output is increased, we call it as polyuria. We call it as polyuria, right? Definition of polyuria is what? Urine output more than or equal to 40 ml per kg per day. Remember here, we are talking about per day here, and it is per hour here. Okay, then we call it as polyuria. And when the urine output is decreased, when it is less than 0.5 ml per kg per hour, So if you are a 50 kg person, right, what should be your normal urine output per hour? 50 kg person, 0.5 ml per kg, so 25 ml per hour should be your urine output. If it is less than that, that means the urine output is decreased. Now we hear two terms, oliguria and anuria, right? When do we call it as oliguria? Oliguria is defined as urine output less than 400 ml per day. In 24 hours, if the patient's urine output is less than 400 ml, we will call it as oliguria. This is our first MCQ point. When do you call it as oliguria? Second, we also hear a term called as anuria. Right? Anuria is equal to urine output less than 50 ml per day. I want you to remember here that in some books, instead of 50, they mention 100. That should also be a fair enough answer. So if you're in the option, they have mentioned 50, go ahead with 50. If they have not mentioned 50, 100 is there, go ahead with 100. If they have mentioned both, stick to 50. Less than 50 ml per day is anuria, less than 400 ml per day is oliguria. Clear? Okay, that is one. Now change in urine output can happen in various conditions, right? When there is kidney injury, generally they will go into oliguria or anuria. When they have diabetes insipidus or other conditions, they can have polyuria. Okay. What is the second symptom that we can expect in a patient with kidney disorders? We can have dysuria, increased frequency of urination and urgency. Now what does that indicate? If any patient is complaining of burning micturition, right, lower abdominal pain, increased frequency, that mostly indicates urinary tract infection. That's a simple question, right? Now other than that, we can have another set of symptoms. Patient may present with periorbital edema, hematuria, proteinuria and increase in blood pressure, hypertension, right? Now if these symptoms are there, we call it as nephritic syndrome. Remember, not nephrotic syndrome, nephritic syndrome. In nephrotic syndrome, you will have a nephrotic range of proteinuria. Now, when do we see nephritic syndrome? It is usually caused by glomerulonephritis. Glomerulonephritis. So basically, when I say glomerulonephritis, it means that the damage is to the glomerulus, right? So if the damage is to the glomerulus, in that case, the patient's presentation will be in the form of periorbital edema, hematuria, proteinuria and hypertension. Clear? Now hematuria can be because of various causes, right? If there is a stone in the kidney, if there is a bladder cancer, if there is hemorrhagic cystitis, if there is ureteral damage, right? In all those cases also hematuria will be there. So how do I identify that this particular patient's hematuria is indeed because of the glomerular injury? Right? The identification comes from the urine microscopy. So when you do the urine microscopy, if hematuria is because of renal injury, if it is because of the renal stones, ureteric injury, urethral injury or bladder injury, the RBCs will look morphologically normal. But if RBCs are there in the blood because of the glomerular injury, in that case the RBCs will become dysmorphed, because when the blood is passing through the glomerulus, because of the glomerular injury, the RBCs are leaking into the filtrate. At the site of injury, the RBCs will be subjected to pressures and they become dysmorphed. So whenever urine report shows that there are dysmorphic RBCs, it basically means that patient has got a disease affecting glomerulus. At least this much we can understand from the question if they says dysmorphic RBCs are present. Okay, clear? Next, if a patient presents with pain in the proteinuria I have already mentioned, yes, albuminuria. Okay. Now if there is pain in the flank and graveluria means small crystallized substances in urine, and if there is hematuria, right, obviously that would indicate that there is renal calculi. If there are stones, then the fragments of the stones may be visible in the urine as graveluria. Hematuria because of the movement of stone might cause injury, and flank pain we know, right? The last but not the least, if a patient presents with loss of appetite, nausea, vomiting with altered RFT, what does that indicate? It indicates uremia, right? It indicates uremia. That means the blood urea levels of the patient are very high. If you have a high blood urea level, remember it is an indication for dialysis. That is why recognition of these symptoms in a question and a patient is important. Okay, so this is basic, right? So if patient presents with change in urine output, several differential diagnoses would be there. A patient presents with dysuria, urgency, frequency, it is UTI. A patient present with periorbital edema, hematuria, proteinuria, hypertension, it is most likely nephritic syndrome indicating glomerulus as the site of injury. A patient presents with frank pain, graveluria and hematuria, it is indicating renal calculi. A patient presents with the uremic symptoms, it indicates patient has got uremia. Okay. Now, few more points that we need to know about hematuria. When do you say that there is hematuria? Because sometimes occasionally 1 or 2 RBCs may be seen in your urine report, right? So we will call it as hematuria when there are more than or equal to 3 RBCs per high power field on microscopy. Then only we call it as hematuria. If there is 1 RBC per high power field, it's not hematuria. Second point, we come across some terms like significant hematuria. Hematuria need not always be significant. So when do you call it as significant hematuria? When the hematuria is persistent, right? We have already defined what is hematuria. When there are more than 3 RBCs per high power field on microscopy, we call it as hematuria. And if 3 separate samples are positive for hematuria, that means there are 3 samples each showing more than 3 RBCs per high power field, then it is significant, right? In that case, we call it as persistent hematuria. Or if in a single sample, we have more than 100 RBCs per high power field, that is significant hematuria. And if the hematuria is visible to the naked eye, gross hematuria, that is significant, right? Anything lesser than that is not significant. For example, only 1 RBC per high power field, or okay, there are 3 RBCs per high power field, but only 1 sample. The second sample is normal. That will not be significant hematuria. Okay, clear? Next, symptom that we need to address is proteinuria, right? Normally what happens? Some amount of low molecular weight proteins will be filtered into the glomerular filtrate, which will be reabsorbed. Okay. But if there is a damage to glomerulus or tubules, there will be loss of proteins in the urine. So that is obviously always pathological. If you have a significant proteinuria, it is pathological. So we need to identify when we consider it as significant proteinuria. Okay. So proteinuria is of 3 types. First, transient proteinuria. That means the proteinuria which is only positive occasionally. That can happen because of various conditions like exercise. So they have asked one MCQ in the past, where do you see transient proteinuria? One of the option was fever. Exercise after fever and after urinary tract infection, proteins may be positive in your urine. You need to ignore that. It is not significant, right? Not significant. Second, we have something called as orthostatic proteinuria. Like if you stand in one particular posture for a long period of time, especially in erect posture, like you're standing continuously for a long period of time, you can have proteinuria. Especially tall individuals will notice proteinuria. That is what we call as orthostatic proteinuria. Tall adolescents may have proteinuria on long standing. Okay. Both of these are benign proteinurias. Nothing needs to be done for them, right? They are safe. But the other conditions where the proteinuria is persistent in more than or equal to 2 samples is a significant proteinuria, right? This is significant. This is significant. Okay. Now, if you have proteinuria, how to differentiate? Because proteinuria can be because of a glomerular disorder. It can also be because of the tubular disorder. So, the most important point is when you have proteinuria, you need to learn to differentiate between tubular and glomerular proteinuria. So let us learn how to differentiate between that. Okay. So if it is a tubular proteinuria, there will be no albuminuria. That means you have protein in urine, but there is no albumin. Then the origin of this protein is from the renal tubules. Okay. If you have albuminuria, as someone already commented, Parth Prajapati commented, if you have albuminuria, that means the protein is coming from the glomerulus. So proteinuria can be differentiated whether it is coming from the tubule or whether it is coming from the glomerulus by looking at whether in the urine albumin is there or only other proteins are there. Albumin present, it is glomerular. Other proteins only present, no albumin, then it is tubular proteinuria. Okay. Now we need to remember some important causes for the tubular and glomerular proteinuria. Okay. What are the important causes for tubular proteinuria? I want you to remember 3 important causes. Okay. Number 1, for the tubular, the multiple myeloma, right? Where you know that there is an M band and a particular monoclonal protein is released in urine, right? multiple myeloma is the first example. Okay, that is a monoclonal protein, only one type of protein. And then the other important causes for the tubular proteinuria are where the tubules fail to reabsorb the protein. So one of them is renal tubular acidosis and second one is Fanconi syndrome. So these three things I want you to remember, 1, 2, 3 as causes for tubular proteinuria. Number 2, for the glomerular proteinuria, there are plenty of causes, and this I will address in tomorrow's session with a table, how to differentiate between different glomerular disorders. So for now, just remember that if you have albumin in urine, the problem is in the glomerulus. If you don't have albumin but still protein, then the problem is in the tubules. Okay. Now, once you have proteinuria and once you clinically recognize that, okay, whether it is tubular or glomerular, the next thing is we need to also assess the severity of proteinuria, especially the glomerular proteinuria. Now, how do we assess the severity? See, albumin is secreted when there is glomerular injury, so we can look at the albumin levels in urine. We obviously have to look at the 24-hour urine albumin, or alternatively, if you don't want to collect the 24-hour urine sample, then you have something called as urine albumin creat ratio. Urine albumin creat ratio. Either one of them can be used. Urine albumin creat ratio is calculated by taking a single sample of urine. You will calculate how much of albumin is there, how much of creatinine is there, and you will take the ratio of that. Okay. One of them is possible. Either collect the urine for 24 hours and calculate the albumin there, or take the urine albumin creat ratio from the single sample. Now, normally, the urine albumin should be less than 30 milligrams per day. Okay. And if you look at the urine albumin creat ratio, also should be less than 30 milligram of albumin per gram of creatinine. Okay. So when it is more than that, obviously there is proteinuria. As long as it is between 30 to 150 milligrams per day, or UACR between 30 to 150 milligram of albumin per gram of creatinine, it is called as microalbuminuria. Okay. And when it is more than 150 milligrams per day, or urine albumin creat ratio is more than 150 milligrams of albumin per gram of creatinine, we will call it as macroalbuminuria. And if it is even more higher, that means more than 3.5 grams, see, not milligrams, 3.5 grams of albumin per day, or UACR more than, urine albumin creatinine ratio more than 3.5 gram per gram of creatinine. In that case, we will call it as nephrotic range proteinuria. Remembering and recognizing nephrotic range proteinuria in question is very, very important, because there are only a few conditions which will present as nephrotic syndrome. So the moment you say that the urine albumin is more than 3.5 grams per day, then you know that you're dealing with a case of nephrotic range proteinuria, and you will be left with only few differential diagnoses for a glomerular disorder. That we will learn tomorrow with a tableized approach. So for now, remember, less than 30 is normal, 30 to 150 micro, 150 onwards it is macro, and more than 3.5 grams it is nephrotic range proteinuria. Okay. So proteinuria is done. We know how to differentiate between tubular and glomerular. Glomerular, albumin present, tubular, no albumin. If it is glomerular, we assess the severity based on 24-hour urine albumin or urine albumin creat ratio. You should know what is microalbuminuria, what is macro, and what is nephrotic range. Okay. The next important symptomatic approach based question that we can anticipate is based on the urine CAS. See, normally what happens is there are something called as Tom Horsfall proteins, right? Tom Horsfall proteins, Tom Horsfall proteins, or THF proteins. These proteins are low molecular weight proteins which are generally passed through the urine, and they can stagnate in your tubules and take the shape of the tubules and form CAS. Okay. So like they are in the shape of the tubule itself. That's why they are called as cast. So on top of this Tom Horsfall protein cast, if I add substances, they will become different types of casts. So all the casts are formed of Tom Horsfall proteins. On top of that, additional substances are added. That is a basic understanding we need to have. Now these casts are classified as cellular and non-cellular. So non-cellular casts primarily are composed of Tom Horsfall protein. If they are purely composed of Tom Horsfall protein, they are called as hyaline casts, right? They are the most common type of cast that we will see in urine. Okay. Apart from that, you have something called as granular cast, fatty cast, and broad cast or waxy cast. In what conditions we see them, I will tell you in a minute. Okay. Then we have a set of conditions where there is a Tom Horsfall protein cast or the hyaline cast, and on top of that other cells are added. Because cells are added, we call them as cellular cast. So if there is a hyaline cast impregnated with RBCs, then we call it as RBC cast. If there is a hyaline cast added with the WBCs, we call it as WBC cast. If there is a hyaline cast added with renal tubular epithelial cells, we call it as RTE cast. Okay. Similarly, this RTA cast, if the cells go into degeneration, it becomes muddy brown, so we call them as muddy brown cast. Now, what questions can be asked to us? Number one, there will be direct question asking you this cast is seen in which condition. Number two, there will be questions where the cast will help you to recognize the problem or condition. Question may not be directly asking you what is the diagnosis, but you will lead to the diagnosis so that you can answer the question. Okay. So first, let me address hyaline cast. As the name says, hyaline, right? They are a sheet of semi-translucent material, right? They are primarily formed of Tom Horsfall protein, formed from Tom Horsfall protein. These are the most common cast, right? And these are seen in normal individuals, right? All of us, when we urinate, we will have some amount of Tom Horsfall protein cast called hyaline cast. They can be increased in number in pre-renal AKI. If there is a pre-renal acute kidney injury, the hyaline cast may be increased in number. Okay. Number two, we have something called as fatty cast, right? So basically, the hyaline cast loaded with fat globules is what we call as fatty cast. Obviously, when do I see fatty cast? When there is too much of lipids in urine. When do we see too much lipids in urine? Two conditions. Number one, most common cause for fatty cast is going to be nephrotic syndrome. See, remember in nephrotic syndrome, apart from proteinuria, right, you have high cholesterol and high triglycerides. It's part of the diagnostic criteria. So obviously, if the blood cholesterol, blood triglycerides are high, urine cholesterol, urine triglycerides will be high, and those triglycerides and the cholesterol will be loaded onto this hyaline cast, making it a fatty cast. The other condition where we might see it is diabetic nephropathy. Okay. Third, RBC cast. So basically a hyaline cast in which RBCs are loaded. In a normal condition, glomerular filtration does not include RBCs. So whatever filtration happens contains proteins, solutes and water, does not contain RBCs. But if there is a glomerular injuries, RBCs will also be filtered and they will be impregnated onto the cast, giving you a RBC cast. So whenever you have a RBC cast, the first thing that should come to your mind is glomerular injury or glomerulonephritis, right? In addition to that, the urine itself might show dysmorphic RBCs. Earlier also I have told you, the moment you see dysmorphic RBCs in a patient with hematuria, start thinking about a glomerular disorder. Clear? Like this. This is your RBC cast. Next we can see WBC cast. Where do we see WBC cast? Obviously the WBC in the circulating urine should be increased to form WBC cast. So in what condition WBCs will be increased in kidney? When you have a pyelonephritis. So hyaline cast, on top of that WBCs are impregnated, giving you a WBC cast. So typically seen in patients with pyelonephritis and acute interstitial nephritis. Right birth. So whenever there is an infection to the kidney, what we call as pyelonephritis, you will have WBC cast. Okay. The next cast is called as RTEC cast. Now what RTEC stands for? Renal tubular epithelial cell cast, right? Renal tubular epithelial cell cast. Okay. When the epithelial cells will be shed, hyaline cast will anyway be formed in normal individuals. When the renal tubular epithelial cells are shed, those shed cells will impregnate the hyaline cast, giving you a renal tubular epithelial cell cast. So obviously there should be injury to the renal tubules. So when there is injury to renal tubules, we will call it as acute tubular necrosis, right? It is seen in ATN, acute tubular necrosis. So when there is a damage to tubules, those cells will be shed, those cells will load on to the hyaline cast, giving you the epithelial cell cast. Same cast, if stays there for a little longer period of time, the cells will be subjected to the autophagy as well as the apoptosis, and there will be release of pigments like lipofuscin, which makes it look brown. So when it starts looking brown, we will call it as muddy brown cast. So now you tell me, where do we see muddy brown cast? Obviously again in acute tubular necrosis. So it is basically a renal tubular epithelial cell cast in which the cells have gone through the apoptosis and degeneration, giving rise to lipofuscin pigment, giving a brown appearance. So muddy brown casts are seen in acute tubular necrosis. Next cast that we see is granular cast. So hyaline sheet where granular material is loaded onto it. That can be seen in two conditions: acute tubular necrosis and chronic kidney disease. Like you see here, it is a sheet where you can see fine granularity. Okay. The last one is broad waxy cast. Look at this cast. It looks like the cast is made from wax. It is broad and it is made from wax. Remember, this is like, in terms of cast, this is the surest evidence that there is CKD. These broad waxy casts are hallmarks of CKD. Hallmarks of CKD. So if I see these casts, I know the patient is having a chronic kidney disease. So almost every alternate year we do expect one question either directly from the cast or information from the cast might be helping you to reach out to the diagnosis. Okay. So this is a basic introduction to nephrology. So we have learnt about the hematuria, how to identify hematuria because of glomerular injury. When there is glomerular injury, hematuria will have dysmorphic RBCs. Then we have learnt about the proteinuria and how to differentiate between the proteinuria coming from the glomerular injury and the proteinuria coming from tubular injury. Tubular injury, there is no albumin in urine. Glomerular injury, there will be albumin in urine. Okay. Now with that background, we will start with the first topic, that is acute kidney injury or AKI. Previously, we used to also call it as acute renal failure and whatnot terms. Now, current context, the terminology is restricted to acute kidney injury. So first thing that they will ask you in MCQ is give you a clinical scenario with this patient's urine output detail or creatinine detail and ask you whether it fits into a condition to be called as acute kidney injury or not. So we decide whether patient has AKI or not based on the KDIGO criteria. KDIGO criteria, right? According to this criteria, a patient is said to have acute kidney injury when his serum creatinine level increases by more than or equal to 0.3 milligrams per deciliter within 48 hours. Okay, so I will give you a scenario. So here I have a patient, right, at day 0 and after 48 hours, I am mentioning his creatinine levels. So at day 0 it was 1.4 and after 48 hours it has become 1.57. Now can I say that he has got acute kidney injury here based on the first criteria? The answer is no, right? What the criteria says? No, the answer should be yes. What the criteria says? 0.3 milligrams per deciliter. So is there 0.3 milligram increase? No, right? Is there 0.3 milligram increase? 0.3 milligram increase here should have meant that it should have become 1.7. Then I could have called it as acute kidney injury. It is 1.57. So it is certainly not acute kidney injury. Another patient whose creatinine was 0.8, it has now become 1.2, right? Can I call this as AKI? 0.8 to 1.2. There is 0.4 milligrams increase in 48 hours of time. So this can be called as AKI, right? So when you see both these patients, all of us may think that, oh, 1.57 creatinine, it is high, this is problematic case, right? And this we may end up ignoring, not as a problematic case, because okay, 1.2 TK. So we have to understand that definition is extremely important. 0.3 milligrams rise in creatinine within 48 hours qualifies to be called as acute kidney injury, or if the serum creatinine increases by more than 50% within 1 week, it can be called as acute kidney injury. Now these are creatinine based criteria, right? Creat based. That's not all. Many conditions the creatinine may not jump, but rather urine output will get affected. So if the urine output, what is normal urine output? Normal urine output is around 0.5 ml per kg per hour. That's what I told you. A 50 kg person is expected to produce 25 ml of urine per hour. So if the urine output is less than 0.5 ml per kg per hour for at least 6 hours, then we will call it as acute kidney injury. See, now if I exercise, during exercise I get dehydrated, next 2 to 3 hours my urine output may be low because I am dehydrated, but as I drink and hydrate myself, my urine output will regain to normalcy. that condition will not be called as acute kidney injury. In that case, after the exercise or after some hot heated environmental exposure, everyone will be defined as AKI. No. When your urine output is less than 0.5 ml per kg per hour for 6 hours or more than that, then we will call it as AKI, right? So this is urine output based. So I want you to memorize or remember this definition. Creat increasing by more than 0.3 milligrams per deciliter within 48 hours, or by more than 50% within 1 week, or urine output less than normal for 6 hours or more, then we will call it as AKI. Now once you diagnose it as AKI, you need to stage it. This is an important MCQ zone, staging of acute kidney injury. There are 3 stages of AKI according to KDIGO. There is one more staging which is called as riffle. I want you to know both because questions have been asked about both. Okay. So according to KDIGO, you have, because in the definition of our diagnostic criteria of the AKI, we had creat based criteria and urine output based criteria. So stage will also have creat based and urine output based criteria. So stage 1 is where patient's creatinine has increased by more than 0.3 milligrams per deciliter, or creatinine has become 1.5 to 1.9 times the baseline. Like, what is the baseline creatinine? Whatever is the patient's creatinine before the onset of renal injury. Let me say that here is a patient whose baseline creatinine is 1.0 milligrams per deciliter. So from 1.0 milligrams per deciliter, if it becomes 1.5 to 1.9 times the baseline, right? 1.5 times of 1.1 is 1.5. So if it becomes 1 to 1.5, then it is stage 1, right? Up to 1.9, it will be considered as stage 1, right? In stage 2, the creatinine becomes 2 to 2.9 times the baseline. So if this one starting creatinine of 1 milligrams per deciliter becomes, let me say, 2 milligrams, or it becomes 2.9 milligrams per deciliter, then it will be called as stage 2, right? If the creatinine becomes more than 3 times the baseline, like 1 was the baseline, from 1 it becomes 3, right, or becomes 3.1 or anything, then it will be considered as stage 3. Okay, there are 2 important parameters to remember here. If the creatinine is more than 4 milligrams per deciliter, regardless of the starting point, it will be called as the stage 3. So let me say that there is a patient whose starting creatinine was 2.3. From 2.3 it has become 4, right? If you just follow the bland criteria, then it is like 2.3 has not become 2 times the baseline, right? It is 2 times the baseline will be 4.6. So it is certainly not even stage 2. I would call it as stage 1 if I go by that definition. But if any value reaches more than 4, it would be considered as stage 3, right? Similarly, if I start the patient on dialysis, regardless of the creatinine level, it will also be considered as stage 3. So there was one FMGE question saying that, okay, here is a patient of whichever matches the higher criteria, whichever matches the higher stage should be taken. We have to look at either creatinine or urine, whichever places the patient at a higher stage, that stage should be assigned to patient. If creatinine stage is 3, urine output stage is 2, then the patient is said to have stage 3 AKI. Okay. So there was one FMGE question saying that, okay, patient's creatinine was 1.1 baseline, and after an episode of hemorrhagic shock, patient's creatinine has become 1.2. Okay, and patient has developed severe metabolic acidosis, anuria, and because of the anuria and metabolic acidosis, the treating doctor has decided to start the patient on dialysis. What is the stage of acute kidney injury? So creatinine had become from 1.1 to 1.3 something, so that even doesn't fit into the definition of acute kidney injury, technically speaking, right? But patient had anuria. So anuria puts the patient into stage 3. Similarly, patient had been started on dialysis, that also put the patient into stage 3. So please be vigilant when you assign the stage to the acute kidney injury patients, and I want you to memorize this table. It is worth spending 5 minutes trying to remember this table. Okay. Second part, urine output criteria. Normal urine output is 0.5 ml per kg per hour. If the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, we will call it as stage 1. If for more than 12 hours urine output has remained less than 0.5 ml per kg per hour, we will call it as stage 2. And stage 3 is where urine output is less than 0.3 ml per kg per hour for 24 hours, or there is anuria for more than 12 hours. So what is anuria? Urine output less than 50 ml per day. In that case, we will call it as stage 3. Okay. Apart from KDIGO, there is also a Riffle criteria or Ripple staging for the kidney injury. So we need to remember what is it. Easy it is, nothing confusing there. So the Riffle criteria stages the acute kidney injury into 5 groups: risk, injury, failure, loss, and end stage kidney disease. Okay. So I don't want you to really bother too much about it, because risk, if you look at the parameters, urine output parameter as well as the creatinine parameter, risk is nothing but KDIGO stage 1. Risk is equal to KDIGO stage 1. Injury is equal to stage 2, and failure is equal to stage 3. So if you have remembered this stage 1, 2, 3, then you already know, right? Risk, injury, failure. So stage 1 according to Ripple criteria is risk. According to the Ripple criteria, stage 2 is injury, and stage 3 will be considered as failure stage. Only thing is that we need to remember 2 more stages, right? What is that? Loss and end stage kidney disease. So if the patient has acute kidney injury persisting for more than 4 weeks, then we will call it as renal loss. And if the kidney injury is persisting for more than 3 months, then we will call it as end stage kidney disease. So now it is about duration. If the duration of acute kidney injury, any of these stage, persisting for 4 weeks, then it is loss. Persisting for 3 months, then it is end stage kidney disease, right? This is what we call as Riffle criteria. Okay. So now we have understood the stages. We will quickly look at the causes for acute kidney injury. We classify the causes for acute kidney injury into 3 categories. Pre-renal, that means the problem is not within the kidney, but probably because of the decreased blood flow to the kidney, there is injury to the kidney. Then we call it as pre-renal. Okay. Then intrinsic renal or renal acute kidney injury. Then last one, kidney is also fine, but the output from the kidney is getting affected because of the obstruction. Then we call it as post-renal acute kidney injury. Okay. Now what are the causes for pre-renal AKI? Single most important cause is hypovolemia. That is the most common cause. So if you have acute GE, you can develop the acute kidney injury because during GE you lost a lot of fluid. After a road traffic accident, because of the hemorrhage you lost blood, hypovolemia, you will develop acute kidney injury. So hypovolemia is the most common cause. Okay. Second, if you have decreased cardiac output, that means the amount of blood coming to kidney is low, you can develop acute kidney injury. Okay. So in that case, we call it as cardiorenal syndrome. Cardiorenal syndrome. So kidney is not the culprit here. The problem is that your heart is not giving sufficient blood to the kidney, so kidney is not able to work. That is cardiorenal syndrome. Okay. Apart from that, there is no true hypovolemia. Cardiac output is also fine, but the circulating volume is altered, like in patients with the liver failure. That can also lead to pre-renal AKI. Okay. Apart from that, the amount of blood that comes to kidney is strictly auto-regulated. Even when your BP is dropping, even when your circulating volume is decreasing, kidney flow is not compromised. It is auto-regulated, right? It is auto-regulated with the help of 2 mechanisms. What is that? If the blood flow to kidney comes down, right, then how can I increase the flow to kidney? See, blood comes to the kidney through an afferent arteriole, right? Then there is glomerulus. This is Bowman's capsule. Intraglomerular pressure is the driving force for filtration, right? So if the flow is coming down, the intraglomerular pressure is also going to come down. Now how can I increase the flow? Simple. There are 2 mechanisms. One, I have to dilate the afferent arteriole and I have to constrict the efferent arteriole. Afferent arteriole should be dilated, efferent arteriole should be constricted. How can I constrict the efferent arteriole? I can constrict the efferent arteriole by activation of the renin-angiotensin-aldosterone system, right? Mainly the angiotensin is an important component here that causes the constriction of efferent arteriole. So if I narrow down the efferent arteriole and I dilate the afferent arteriole, how will I be able to dilate? With the help of prostaglandins. Prostaglandins are the important. Prostaglandins will cause dilation. So if I dilate, flow increases. If I constrict, outflow decreases and pressure inside the glomerulus will increase, and I will be able to still get the glomerular filtration done. Okay. Now what can impair this autoregulation? Right? If I give NSAIDs, I will inhibit prostaglandin synthesis, right? We know NSAIDs cause kidney injury. Why? Because they will inhibit prostaglandin synthesis. So we will lose the autoregulation. So if there is a decreased flow to kidney because of dehydration or whatever cause, the afferent arterial dilation cannot happen because the prostaglandins are being blocked by NSAIDs. That is why NSAIDs are an important cause for acute kidney injury. Similarly, ACE inhibitors and ARBs, they will block the RAS. So they will not be able to cause the constriction of efferent arteriole. That is why they can also cause acute kidney injury. Okay, so these are all pre-renal causes for acute kidney injury. MCQ wise, they will ask you what is the most common cause. Most common cause is hypovolemia. Okay. Then acute kidney injury can also happen if the problem is within the kidney. What can go wrong within the kidney? See, kidney has basically a nephron. Nephron has glomerulus and the tubules and the blood vessels around the nephrons and the interstitium. Anything can get affected, right? So if the glomeruli are injured, we call it as acute glomerulonephritis. Plenty of causes are there like post-streptococcal glomerulonephritis, and we can study a lot of glomerulonephritic conditions. All of them can cause acute kidney injury, right? Then the renal tubules can get damaged. What is the function of tubules? Reabsorption. So if the tubules are damaged, we will be losing the reabsorption, and then we have acute kidney injury. In what conditions tubules can get damaged? Number one, ischemia, because tubules need blood supply. If the BP drops, the blood supply to the kidney tubules, the proximal convoluted tubule, loop of Henle, and distal convoluted tubules and the collecting ducts will be lost or decreased. That will cause the tubular injury. Okay. Then sepsis is another important cause. In sepsis, inflammatory cytokines are increased. They can directly cause the damage to tubules. Then there are a lot of nephrotoxins. For example, aminoglycosides. They are nephrotoxins which can directly cause the damage to tubules, right? Example, aminoglycosides, right? Another example I can give is acyclovir. How acyclovir will cause the renal tubular injury? Acyclovir will precipitate as crystals in the tubules and block the tubules. Okay. Then the blood vessels that are around the tubules, they can also get damaged. In what conditions? In vasculitic conditions. We have studied a lot of vasculitic conditions in rheumatology, all of them. Then you might have heard about thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, and you might have also heard about malignant hypertension. These are all vascular causes for intrinsic renal AKI. Now AKI can also be because of post-renal causes, where the problem is not in the blood flow to the kidney, the problem is not in the kidney also. Blood flow is normal, kidneys are doing their job normal, they are producing the urine normal, but the urine is not able to exit the system because there is some obstruction, either uretropelvic obstruction or bladder outlet obstruction. Now when I get a case of acute kidney injury, I have to recognize whether it is pre-renal, renal or post-renal. The easiest to recognize is post-renal, right? Because imaging will help me identify the site of obstruction, right? So that is why whenever we have acute kidney injury, we get an ultrasound done. If ultrasound shows that there is a bladder outlet obstruction or ureteric obstruction or a pelvic obstruction, then I know, okay, it is a post-renal cause, right? If there is no obstruction, post-renal is ruled out, then I have to think of pre-renal versus intrinsic renal. And plenty of questions have been asked about, if you have a patient with AKI, how do you differentiate between pre-renal and the intrinsic renal? That too, more precisely, the AKI because of the pre-renal, and within the intrinsic renal, the tubular damage, right, where we call it as acute tubular necrosis. How to differentiate between ATI, ATN and pre-renal AKI. So I will address that. But there's one more question. If I get a patient whose creatinine is elevated or urine output is low, I cannot solely depend on the history saying that this is AKI, because patient might not have recognized the decrease in urine output, or patient might not have done his creatinine in the past. This is the first creatinine that we are seeing and it is high. So how do I know that it is CKD or AKI? What is the best investigation that helps us to differentiate between CKD and AKI? The answer for that should be imaging. Imaging would be the best investigation that helps us to differentiate between the AKI and CKD. How it helps? If there is a chronic kidney disease, right, like whatever may be the cause, the most common cause for CKD is diabetes. Other than that, it is hypertension and chronic glomerulonephritis. In all those cases, there is scarring of the kidney and the kidney will become shrunken. So if the imaging shows that kidney size is decreased, then it is clearly a case of CKD. If the imaging shows that the kidney size is normal, yet your creatinine is altered, then it is mostly a acute kidney injury. So that is why the best bet or the best investigation to differentiate between the AKI and CKD right? AKI versus CKD. The best method to differentiate will be imaging. And within imaging, right, ultrasound is the most convenient imaging. Ultrasound is the most convenient, right? That will be very cost effective and quickly the result will be available. In ultrasound, what should I look for, right? If abnormal CKD would show two important features, right? One, shrunken kidney. The kidney size will be decreased. Shrunken kidney, or in other words, small sized kidney. Second thing, there will be loss of corticomedullary differentiation. Corticomedullary differentiation. So look at the images here. Differentiation. So look at the images here. This is a normal kidney. We can see the medulla and we can see the cortex, right? Renal cortex and medulla can be clearly differentiated. And in case of CKD, we can notice that the size is smaller in comparison to normal kidney. And where is the cortex? Where is the medulla? Don't know, right? Loss of corticomedullary differentiation. These are the best evidence to say that a particular case is of CKD. And this image-based question has appeared in the past. Questions related to it have appeared in the FMGE, like what is the best investigation to differentiate between AKI and CKD, right? Imaging. If they ask you pick one, choose ultrasound because that is the most convenient and simplistic investigation. Okay, the next challenge. We have now differentiated between acute kidney injury and CKD in a patient presenting with abnormal RFT report. Now, if I know that this is a case of AKI and if imaging doesn't show that there is an obstruction to the bladder or the ureters, then I know it is not post-renal. It has to be pre-renal and intrinsic renal. Intrinsic renal, the most common cause is acute tubular necrosis. So how do I differentiate between these two, right? So I'm going to give you one table and I will highlight 3 important points for you to remember. That should be enough for you to differentiate between ATN and pre-renal AKI. Pre-renal AKI versus acute tubular necrosis. Number 1, that will be your urine specific gravity. Okay. Number 2, that will be fractional excretion of sodium or FeNA. Okay. Number 3, that will be urine osmolality. Okay, so let me take you back to the basic renal physiology. What is the basic renal physiology? The function of the glomeruli is to filter the blood, right? The filtrate is called as glomerular filtrate. What is the function of tubules? To reabsorb wanted substances and water from the glomerular filtrate. Okay. Now, if I have a pre-renal AKI, means what? The blood supply to kidney is decreased. Now you only tell me what is your expectation from the kidney. If kidney is getting less blood supply, that means circulating blood volume is low. So at this point of time, kidney should excrete concentrated urine or excrete too much water if the blood supply to the kidney is less. I just told you that if there is decreased blood flow to the kidney, there is activation of RAS, renin, angiotensin, aldosterone axis, right? So once RAS activates, there is aldosterone in it, right? What aldosterone will do? Aldosterone will push the kidney to reabsorb sodium, right? Reabsorb sodium, reabsorb water, giving you a very concentrated urine. All of us have experience, right? We don't drink water from morning to evening. Evening our urine is extremely dark because urine becomes concentrated. So if you have a pre-renal AKI, simplest way to remember the features of pre-renal AKI is concentrated urine, right? You will have concentrated urine. But instead, if you have an acute tubular injury, tubules function is reabsorption. If there is injury, tubules fail to reabsorb. So you lose water, you lose solutes. So you will have a dilute urine. Urine will not be extremely concentrated, right? Simple. Second, if you have acute tubular necrosis, there is no need for activation of RAS. So there is no aldosterone coming up. So there is no sodium reabsorption. So you will be losing a normal quantity of sodium, right? Clear? Now, first feature, urine specific gravity. In case of pre-renal AKI, because there is concentrated urine, the urine specific gravity will be high, right? It will be more than 1.020. In case of acute tubular injury, reabsorption is failed, so we are not able to concentrate the urine. Urine will be dilute, so urine specific gravity will be less. Okay. Second, fractional excretion of sodium. So from the filtrate, what percentage of sodium is lost in urine? In case of pre-renal AKI, because there is activation of RAS, aldosterone will make you reabsorb most amount of sodium. So you will excrete less amount of sodium in urine. So your FeNA will be less than 1%. In case of acute tubular necrosis, there is no activation of RAS. So there is no increased sodium reabsorption. So you will lose more amount of sodium in urine. So your FeNA will be high. The single most important investigation that helps you to differentiate between pre-renal AKI and the acute tubular necrosis is FeNA. That is FeNA, and that is why, like, just remember, pre-renal AKI, activation of RAS, increased sodium reabsorption. Acute tubular necrosis, no activation of RAS and damage to tubules, so sodium reabsorption will be impaired, you will lose more sodium. That is why FeNA will be high in case of acute tubular necrosis. Okay. The third one, urine osmolality. If the urine is highly concentrated, obviously urine osmolality will also be high, right? So in pre-renal, urine osmolality will be high. In case of tubular, tubules are supposed to reabsorb, tubules are not able to reabsorb, we are not able to concentrate the urine, and the urine osmolality will be low. These three are important features. If you remember this, or if at least remember the logic, pre-renal AKI, low volume, kidney trying to concentrate the urine, then acute tubular necrosis, damage to tubule, kidney is not able to reabsorb and you are losing everything in urine. If you remember this concept, you will be able to differentiate between pre-renal AKI and acute tubular necrosis. Okay. Now last point, coming to the management. How do you manage a case of AKI? Obviously it depends on the cause, right? If it is pre-renal, right, number one, treat underlying cause. If you are given NSAIDs, withdraw, right? If you are giving any other substance which is known to alter the renal autoregulation, for example ACE inhibitors, ARBs, stop, right? Then if there is hypovolemia, give a generous hydration, right? Hydration. On the other hand, if it is renal or intrinsic renal, again the management will be treatment of the cause. Like if acute tubular necrosis is there, it can be caused by drugs or whatever cause, treat it, right? And remember, pre-renal can lead to acute tubular necrosis. In that case, again, hydrate the patient well. Okay. And if it is post-renal, there will be an obstruction as a general cause. So we have to relieve the obstruction. Okay. Now, what are the complications of acute kidney injury that we can expect? The complications, important ones that I will list here. Number one, uremia, right? Number two, you can develop hyperkalemia, because it is the function of the kidneys to excrete potassium, and if there is a dysfunction, potassium excretion will be affected. Okay. Number three, metabolic acidosis. Okay. Now, how do you treat these complications? Uremia can only be treated with dialysis, right? If symptomatic, uremia, if there is symptomatic, there is no way to decrease the blood urea level. We have to treat the patient with dialysis. Okay. If there is hyperkalemia, right, first we will offer the patient to go through anti-hyperkalemia measures, right? What are the anti-hyperkalemia measures? You know, what can bring down the potassium levels? What can bring down the potassium levels? You can give dextrose plus insulin. How dextrose plus insulin will work? Insulin will help us shift the potassium from extracellular to intracellular compartment. But because insulin can cause hypoglycemia, we might have to add dextrose. In a high diabetic patient, you need not give dextrose. You can just give insulin, right? What other things we can do? We can give salbutamol nebulization. How this will work? Same as insulin. This will also shift the potassium from extracellular to intracellular environment. So blood potassium level will come down, right? Then we can also give potassium binders, which will like bind the potassium from the GIT and help you lose potassium in your gut rather than absorbing it from the gut. These are all the measures we can do. If despite that potassium is high, then we can go for dialysis. And we can also give calcium gluconate to protect the heart, because hyperkalemia hits the heart causing the arrhythmias. So we can protect the heart by giving the dialysis, by giving the calcium gluconate. Similarly, if there is metabolic acidosis, you can treat it with sodium bicarbonate. And if that is not helping, you can go for dialysis. So there will be one question asking you, Prajapati, yes, calcium gluconate generally does not bring down the potassium. What it does is it desensitizes the cardiac myocardium to the impact of hyperkalemia so that the arrhythmia risk comes down. That's why we give the calcium gluconate. Okay, now they can ask you among these which one is an absolute indication for the initiation of dialysis, right? Obviously that is symptomatic uremia because urea cannot be brought down with drugs. Hyperkalemia is not an absolute indication, it is a relative indication. First, I will give dextrose insulin, salbutamol nebulization, calcium gluconate and potassium binders. Still hyperkalemia or some fatal arrhythmia is occurring, then I will take the patient for dialysis. If there is metabolic acidosis, I will give the sodium bicarbonate. I am not able to correct it, then I will take the patient for dialysis. But if there is uremia leading to symptoms, I don't have any other choice, I have to go for dialysis. So symptomatic uremia is an absolute indication for dialysis. So that is again an important MCQ. Indication for dialysis. Okay, so that about the acute kidney injury. We will move to the chronic kidney disease or CKD. Okay, now when it comes to chronic kidney disease, right, how to differentiate between acute kidney injury and CKD? The best investigation is imaging. If you have altered renal functions, creatinine high, urea high, and a shrunken kidney or loss of corticomedullary differentiation in the kidney, it is a case of chronic kidney disease. Now what are the causes? I want you to remember only two important causes because MCQ wise that's what they can ask. First thing that they will ask you is what is the most common cause for CKD. The most common cause for CKD is diabetic nephropathy. Diabetic nephropathy. So I will call diabetes mellitus as the most common cause, right? Diabetic nephropathy. In India, this accounts for 2/3 of all cases. 2/3 of all cases. So if you go into any of the nephrology unit or hospital, right, 2 out of 3 patients have CKD because of the diabetes mellitus. Okay. Now after diabetes mellitus, what is the second most common cause? The second most common cause is hypertension. We call that as hypertensive nephropathy. Hypertensive nephropathy, right? This accounts for around 20% cases. So that means these two together account for like 4 out of 5 patients of the CKD are because of the diabetes and hypertension. Remaining causes are relatively rare causes for CKD, right? What are the other causes? Number one, your chronic glomerulonephritic conditions, chronic glomerulonephritis. Okay. Then number two, your cystic kidney diseases like autosomal dominant polycystic kidney disease, cystic kidney diseases. Number three, drug induced. These are all relatively rare causes, right? Number four, lupus nephritis. So most cases are because of diabetes and hypertension. Okay. Now once we have understood the causes for CKD, we need to know how do we stage patients of CKD, right? Unlike the acute kidney injury staging, the staging of the CKD patient takes into account 2 parameters. We have to stage them based on number one, GFR, and number two, proteinuria. So any patient of CKD will be assigned 2 numbers. GFR based, it will be generally addressed as stage G, G1 to 5, and proteinuria side we will assign the stages A1 to A3. So any patient will have a G number and a number like G1 A3 or G2 A2. So let us understand how to recognize the stage based on the GFR, how to recognize the stage based on the proteinuria. Looking at the estimated GFR, tomorrow we will learn how to calculate the GFR from the Kovcroft-Gault formula. So tomorrow's session I am keeping it only for those table based questions and formula based questions. Okay. So estimated GFR, normal GFR is 90 to 120. So if the GFR is more than 90, then we will call it as stage 1. 60 to 90, that is stage 2. Okay. 45 to 59, that means 45 to 60 is stage 3A, and 30 to 44 is stage 3B. Stage 4 is when you have 15 to 29, and when it is less than 15 it will be called as stage 5. And also remember, any patient started on dialysis regardless of their estimated GFR will be considered as stage 5, right? Same applies to acute kidney injury. Any patient of acute kidney injury who is started on dialysis will be stage 3. Similarly, a CKD patient, if they started on dialysis, it will be automatically stage 5, right? Should I remember these numbers? Absolutely yes. You need to remember the number, right? 90 or higher, stage 1, 60 to 89, stage 2, 45 to 59, stage 3A, then 30 to 44 is stage 3B, then 15 to 29 is stage 4, and less than 15 is stage 5, or on dialysis is stage 5. That will give you the G number of staging. Now I have to also identify the A number of staging. That is based on the proteinuria. Okay. So if the urine protein levels are less than 30 milligrams per deciliter, that's as we know that is a normal protein, right? In that case it will be called as stage A1. If it is 30 to 300 milligrams per day, it will be called as A2, and more than 300 milligrams per day, it will be called as A3. So let me give you a small exercise here, right? Assign the stage for this patient. Assign the stage. Okay, so I have a patient whose estimated GFR, right, eGFR of the patient is 32, and his urine protein estimation or urine albumin estimation shows that it is around 150 milligrams per day, right? So which stage it is now? Which stage it is? These kind of questions are going to be common for us. More than 90 is stage 1, right? 60 to 89 is stage 2. So obviously lesser than that, it must be stage 3. Right, in stage 3 we have stage 3A and 3B, right? 3B is 30 to 44 and 3A is 45 to 59. So looking at this, it becomes a case of 3B, right? G number will be 3B, right? And A number, for A number we have to look at the albumin or urine protein, right? Urine protein less than 30 is A1, 30 to 300 is A2, more than 300 is A3, right? Again, it is easy to remember, 3 for 3. More than 300 is A3. Less than 30, anyway we know normal, that is A1. Anywhere in between will be A2. So this proteinuria wise, this is A2. So this patient's CKD stage will be G3B-A2. G3B-A2. That is how we assign the stage. This year I am expecting a question on this, so I would suggest that please memorize this table. Okay, clear? Now we have understood what are the common causes. What is the most common cause? That is diabetic nephropathy. What is the second most common cause? That is hypertension, right? Other causes you don't need to remember. Then we have learned how to stage the CKD. Now why CKD is such an important disease? Because it leads to myriad complications. So what are the complications? Number 1, kidneys are supposed to eliminate urea. Now urea comes from where? Urea comes from liver, right? From where the liver forms the urea? It forms the urea from ammonia. Ammonia is a highly toxic substance. Liver converts the ammonia into urea, and urea is easy for the kidneys to eliminate. So as long as kidneys are fine, urea is not a problem. But if the kidneys are not fine, the urea level increases. Urea is also toxic. It is not as toxic as ammonia, but it is toxic. It is toxic to brain, gut and various tissues. So it leads to various symptoms, right? What are the symptoms uremia can lead to? 1, lack of appetite, severe nausea and vomiting. Appetite, severe nausea and vomiting. Second, urea can also cause uremic pericarditis. Uremic pericarditis, right? Then urea can also cause hemolysis. That's why we have conditions called as uremic hemolytic syndrome and all. Urea can also trigger hemolysis. Then urea can cause platelet dysfunction. Platelet dysfunction leading the risk of increased bleeding risk. So urea is toxic. Okay. And worst, urea can cause something called as uremic encephalopathy. So if you have attended offline classes, you might know that high urea levels can, we had seen that video where that female had this flapping tremors, right? High urea level causes uremic encephalopathy where you can develop flapping tremors, right? So that is one set of complication, most feared complication, because there is no way to manage uremia with drugs. You have to go for dialysis only, right? The second thing is kidneys are supposed to eliminate water. If they are not able to do that, then patient takes in the fluid, doesn't go out through kidney because patient has got anuria or oliguria. So all that fluid will stay in body, fluid overload, right? So this fluid overload can lead to pulmonary edema, as well as it can contribute to heart failure, because that extra fluid needs to be pumped by heart. Okay, then plenty of electrolyte abnormalities, right? What are the anticipated electrolyte abnormalities? Number one, the kidneys are supposed to eliminate potassium, right? And once they're not able to eliminate potassium, hyperkalemia is certainly a concern. Okay, number two, kidneys are supposed to eliminate phosphate. Once the kidneys are affected, phosphate elimination gets affected, and we can have hyperphosphatemia. Okay, I want you to remember here that other electrolyte abnormalities can happen in different kidney disorders. Like for example, in some kidney disorders you can have hypokalemia. In some kidney disorders you can have hyponatremia. You can have hypernatremia. But when it comes to phosphate, it is always hyperphosphatemia. When kidneys fail, phosphate cannot be eliminated. There is no other way to eliminate phosphate. So kidneys fail, phosphate rise. Simple. Right? So you never see hypophosphatemia in kidney disorders. You can see hypokalemia, you can see hyponatremia, hypernatremia, but no hypophosphatemia, right? You have to remember that. Then the CKD will also lead to anemia, right? We call it as anemia of CKD, right? Various causes are there. What are the causes? Number one, because of the uremia, they have decrease in appetite, severe nausea, vomiting. So their food intake comes down. So they have nutritional deficiency. They can have iron deficiency. So that is one contributing cause. Okay. Second, kidneys are concerned with production of erythropoietin. So if kidneys are not able to do their work, there will be erythropoietin deficiency. Erythropoietin deficiency. That is a second cause. Third, because of the uremia, there is increased bleeding risk, right? So the bleeding also contributes to the loss of blood. All of these are factors contributing to anemia of CKD, but the most important reason is erythropoietin deficiency. That is why when we have to treat anemia in CKD patients, we might need to give them erythropoietin. Okay. Other than that, there is something called as CKD related mineral bone disease. I will discuss that in a little bit detail because MCQs have been asked frequently on that. CKD related mineral bone disease, because kidneys play an important role in regulation of the blood calcium levels. How? We will understand now. Last point, patients with CKD have increased risk of ischemic heart disease, right? MI or chronic IHD, chronic stable angina, unstable angina. The risk is high in patients with CKD. Many reasons. Patients with CKD are mainly diabetic, they are hypertensive, so they have other risk factors for ischemic heart disease. Then once there is CKD, elimination of certain toxins, including lipids, gets affected. So blood cholesterol levels can increase, and that also contributes. So several reasons are there. Increased calcium can cause calcification of blood vessels. That is also a reason, right? And I want you to remember one MCQ point, right? Cardiovascular disorders are the most common cause of death in CKD patients. CKD patients don't die generally because of uremia or generally because of electrolyte abnormalities, because we can treat. They mostly die, majority of them die because of the ischemic heart disease. Okay. Now let us address two of these important complications, anemia and CKD related mineral bone disease. Let me first take up with the CKD related mineral bone disease. MBD stands for mineral bone disease. Okay. So now what is the basic pathology? In kidney disorders, there are two major abnormalities that happen. Number one, and if you ask me, the single most important abnormality that happens is the failure to excrete phosphate, right? This is the most important pathogenic component for the changes in the bone that happen in patients with CKD. Okay, because there is no other way for us to eliminate phosphate. So if the blood phosphate levels increase because of the CKD, that will trigger the activation of something called as FGF23. This FGF23 is called as a phosphatonin, which is supposed to push the kidneys to eliminate more phosphate. But unfortunately, it is a damaged kidney. It will not be able to do that job, right? Unfortunately, this FGF23, right, inhibits the WNT beta catenin pathway, which is supposed to stimulate the mineralization or deposition of calcium in the bone. And by activation of this, we are decreasing the calcium deposition in the bone. That is the first problem. So the bone calcium levels will start decreasing because we have activated FGF23. Okay. Second, the kidney plays an important role in the synthesis of vitamin D, right? Because one of the hydroxylation reaction happens in the kidney. The active form of vitamin D is 1,25-dihydroxycholecalciferol. So one level of hydroxylation happens in liver, the second happens in kidney. In the kidney, if there is no hydroxylation happening, then the active form of vitamin D decreases. And what is the function of vitamin D? Vitamin D stimulates the gut or your intestines to increase the calcium absorption. So if there is a active form of vitamin D very low, then your intestines will not be able to absorb the calcium sufficiently and your blood calcium level will start decreasing. When the blood calcium level start decreasing, obviously body cannot keep quiet. It has to make an attempt to increase the calcium. How will it make? Its best bet is to stimulate the parathormone, right? So this hypocalcemia triggers parathormone production. So we have what we call as secondary hyperparathyroidism. Hyperparathyroidism in patients with CKD. Why is it secondary? Because the problem is not because of hyperactivation of the parathyroid gland. It is because of the hypocalcemia that your parathyroid levels are increasing. Once they increase, how parathyroid increases the blood calcium level? Simple. Parathormone will remove the calcium from the bone and put it into the blood. So it causes the bone lysis to increase the blood calcium. So there are two hits happening to the bone. One, FGF3 is inhibiting the mineralization. Second, whatever mineralized bone is there, from there calcium is being taken out with the help of parathormone. So now what will happen to the bone? Bone will lose the calcium, right? Bone will lose the calcium. Then how will it come to light? It will mainly come to light either because of increased fractures, or second, there is development of what you call as brown tumors. Osteolysis leading to brown tumors. Like the loss of calcium here, you can see that is what we call as brown tumors. So brown tumor formation can be one of the complication of the CKD. Okay. Similarly, calcium loss from your spine increases the risk of the vertebral fractures, and when you do an imaging, it gives rise to a peculiar appearance. Like when you look at that, because of the loss of calcium, the spine looks like the checkered t-shirt, right? And we call this sign as rugger jersey spine. So there was an MCQ in the FMGE asking you where you see rugger jersey spine sign. Rugger jersey spine. Rugger jersey spine is seen in patients with CKD. Okay. Now if I have a patient whose bones have lost the mineral, right, because of the CKD, now how do I treat it? What is the principal pathology? It is the hyperphosphatemia which has triggered the abnormalities, right? So I have to primarily focus on decreasing the hyperphosphatemia, right? How do I decrease the hyperphosphatemia? Primarily I have to reduce the dietary intake of phosphate. I have to reduce the phosphate intake to less than 900 milligrams per day. Second, I have to give drugs which will bind the phosphate. Whatever phosphate that is coming from the diet, the drugs will bind and stop you from absorbing and make you lose it in stool, right? So there are two examples of phosphate binding agents. One of them is calcium acetate. Second one is sevelamer, right? I want you to remember sevelamer because it appears in questions once in a while. What is sevelamer? Sevelamer is a phosphate binding resin or a phosphate binder. And what is the target phosphate levels, right? We need to maintain a target phosphate level. What is the target phosphate level? The target phosphate level is 3.5 to 4.5 milligrams per deciliter. Okay. So you should maintain that so that the bone health is unaffected. Second, because there is hypocalcemia and vitamin D deficiency, you can give the vitamin and calcium supplementation. Okay. What else we can do? We can trick, right? Because there is the bone calcium loss is also triggered by parathormone, right? So we can trick the parathyroid gland to believe that there is sufficient calcium even when there is low calcium. How can we trick? Because if the parathormone level increases, it will come and clear the calcium from the bone. Bone will lose the calcium. It will develop the brown tumors. It will develop the rugger jersey spine. So if I give drugs which make the parathyroid gland think that there is sufficient calcium in the blood, then the parathyroid levels will come down. Those classes of drugs are called as calcimimetics, right? Calcimimetics. They are mimicking the function of calcium, right? So examples, two of them you need to remember. One is etacalcide and cinacalcet. calcite. These are calcimimetic agents. So basically in the parathyroid gland there is a receptor which senses how much calcium is there in the blood. Those receptors are called as, they will actually stimulate that receptor. That receptor is called as CASR. CASR stands for calcium sensing receptor. This is basically calcium sensing receptor. This is present on parathyroid gland. So if parathyroid gland, if these substances go and stimulate the CASR, the parathyroid gland thinks that there is sufficient calcium in the blood, so it will stop the parathormone release. And if there is decrease in parathormone release, then that bone calcium clearance that is happening under the influence of parathormone will come down. Clear? Okay, so that is how we manage a case of calcium and the mineral bowl abnormalities in CKD. The last point I want you to learn today is how do we manage the anemia in CKD. Anemia in CKD. Okay. As I have already told you, anemia in CKD is multifactorial. It can be because of various causes. Multifactorial. Right? Important causes for anemia in CKD. Number 1, erythropoietin deficiency. Number 2, there can be iron deficiency. And number 3, there is increased risk of bleeding because of uremia. Uremia causes platelet dysfunction. Okay. Now, what is the nature of anemia? Theoretically speaking, the anemia in CKD is of anemia of chronic disease type, right? What is the anemia of chronic disease type anemia? It is normocytic, normochromic. But in reality, right, exam wise, yes, it is the anemia of chronic disease type, normocytic, normochromic anemia. But in reality, most of the patients of CKD will have iron deficiency. So what we see is microcytic hypochromic anemia. But for the exams, the answer is normocytic, normochromic anemia. Okay, there is erythropoietin deficiency. Now, if I have to treat the anemia of CKD, how should I treat? Number 1, there should be iron replacement. Why? Because iron deficiency is an important contributor. See, if I just give erythropoietin, the hemoglobin level is not going to improve because erythropoietin will stimulate the bone marrow. But where is the raw material for hemoglobin formation if the iron is low, right? Still you will not get the good response. So first, replace the iron. Second, we have to give erythropoietin replacement, right? Either with EPO, erythropoietin injection, or there is a erythropoietin derivative called as darbepoetin, right? Here darbepoetin is preferred. Why is it preferred? Because of higher efficacy and longer action. So you can give darbepoetin once a week or twice a week. You don't need to give it on a daily basis. Erythropoietin would require more frequent administration. So that is why darbepoetin is a preferred agent. Clear? Now you have to also remember one important side effect of the erythropoietin replacement therapy, right? Side effect. What is a side effect? Erythropoietin not only stimulates the RBC synthesis, it can also stimulate the platelet production, leading to increased risk of thrombosis. So one of the concern with erythropoietin therapy is increased risk of thrombosis. The reason I am talking about it is there was a question in the FMGE about this. A patient was started on erythropoietin. He presented with leg swelling. What do you suspect? A deep vein thrombosis should have been the answer. Okay. Now I have understood that I should replace iron. I should replace the erythropoietin. Third, you can do blood transfusion if the hemoglobin is less than 7. Now, should I treat this patient's anemia to the point where hemoglobin becomes normal? The answer is no, right? So we should know the target hemoglobin. How much iron I should give, how much erythropoietin I should give. The target hemoglobin is around 11 grams per deciliter. You don't need to push their hemoglobin to all the way to normalcy, that is 14 plus, right? 11 grams of hemoglobin is more than enough for these patients to carry out normal internal organ function. Okay, so that is about the CKD. Now we will conclude by taking some quick PYQs. And what is pending from nephrology now? The glomerular disorders. There are two kinds of questions that you can get from the glomerular disorders. One is the clinical decision or clinical diagnosis, which I will discuss today in a tabular form, tomorrow in a tabular form. Second is the pathological diagnosis based on the light microscopy, electron microscopy findings that you have to learn from the pathology. Okay, so let me start with some of the quick questions. Here is a PYQ number 1. All of the following are causes of acute kidney injury except, right? So I will wait for you to answer. Which of them is not a cause of acute kidney injury? Snake bite, pyelonephritis, rhabdomyolysis, analgesic nephropathy. Okay, pyelonephritis, we know it is a acute kidney injury. That too, which one? Intrinsic renal type of acute kidney injury, right? Can rhabdomyolysis cause acute kidney injury? What is rhabdomyolysis? Lysis of the muscle, right? Damage to muscle and muscle proteins will be leaked. Now what these muscle proteins will do? They will get filtered in the glomerular filtrate, go to the renal tubules, precipitate there, block the renal tubules and cause tubular injury. So rhabdomyolysis leads to myoglobinuria, and that can lead to acute tubular necrosis. So acute tubular necrosis is obviously a acute kidney injury, right? Now snake bite can cause acute kidney injury in two formats, right? One, the venom can cause interstitial nephritis, right? Interstitial nephritis is a type of not pre-renal. Interstitial nephritis is a type of intrinsic renal AKI, right? Interstitial nephritis is intrinsic renal. Second, there are myotoxic snake bites which cause compartment syndrome and the muscle damage, right? So basically there can be rhabdomyolysis, and I have already told you rhabdomyolysis will lead to acute tubular necrosis, right? So that is also basically a intrinsic renal type of AKI, right? All are intrinsic renal type of AKI. Now analgesic nephropathy, like the chronic use of paracetamol, causes papillary necrosis, and whenever there is a structural damage to kidney, generally it is in the form of chronic injury, right? That's what we have learned. The best investigation to differentiate between AKI and CKD is ultrasound, because it will show the structural change in the kidney. Analgesic nephropathy causes renal papillary necrosis on chronic use of analgesics. So this is not a acute kidney injury. It causes what we call as CKD, right? It causes CKD. Analgesic use for a short term can cause acute kidney injury, but generally that will be counted as a pre-renal AKI. Remember, when we discussed the AKI, we classified them into pre-renal, renal and intrinsic renal, right? Pre-renal, the analgesics or NSAID use will impair the autoregulation, and any slight decrease in the blood flow to the kidneys will fail because they are not able to get the sufficient blood supply. They have lost the autoregulation, because when you give NSAIDs, you are blocking prostaglandins, you are inhibiting the afferent arterial dilatation. So this will be AKI, but when you chronically take analgesic, they will develop renal papillary necrosis, and that is a CKD. So what should be the answer for the first question? The answer for the first question should be option D. Option D would be my answer here, right? Answer would be option D. That would be the answer. Okay. Second question. Non-oliguric acute kidney injury is usually seen with. You only need to remember the answer here. Most of the acute kidney injury, the urine output comes down. That is why in the AKI definition itself, we have a urine output criteria. But why we have a creat criteria and urine output criteria? Because there are some conditions where the urine output will not be affected. Only the creatinine will rise. That is also AKI. We will call them as non-oliguric acute kidney injury, right? Snake bite, we are blocking the tubules. Snake bite causes rhabdomyolysis. The myoglobin precipitate in the renal tubules and causes the tubular injury. So if the tubules are blocked, there is no flow happening and you will have oliguria. If there is hypovolemia, right? It is a typical example for a pre-renal AKI. Obviously, you will have a concentrated minimal urine production. So you will have oliguria, right? Septic shock, again, the kidneys are not getting sufficient blood supply. You will have oliguria. But aminoglycoside toxicity causes non-oliguric Oliguric. So it causes tubular injury not by blocking the tubules but rather destroying the tubular epithelial cells. So reabsorption will get affected. So sometimes in aminoglycoside toxicity you can even have polyuria with high creatinine, right? So the all other cases are of the oliguric type. So option C would be the answer for this question, right? Yashwardhan Prajapati, right? Okay. Third point, FeNA less than 1 indicates. This question has appeared at least 5 times in the FMGE. FeNA less than 1 indicates. FeNA is fractional excretion of sodium. From the glomerular filtrate, how much percentage of sodium is lost in urine and how much is reabsorbed? So remember, FeNA is the best investigation to differentiate between pre-renal AKI and acute tubular necrosis, right? So in pre-renal AKI, the pre-renal AKI is because of the decreased blood flow to the kidney. So when the blood flow to the kidney decreases, there is activation of RAS. RAS has aldosterone. Aldosterone increases sodium and water reabsorption. So you end up losing less sodium in urine and more sodium is reabsorbed. So the fractional excretion of sodium will be less when there is pre-renal AKI. If there is acute tubular necrosis, there is no activation of RAS and tubules are the sites of the electrolyte reabsorption. Reabsorption won't happen, so you will lose a lot of sodium. So the answer for this question would be obviously pre-renal azotemia. Azotemia is another term for renal dysfunction. So option A would be the answer. So remember here, FeNA less than 1 is equal to pre-renal AKI. Okay. And FeNA more than 2 is equal to acute tubular necrosis. So whenever you have a doubt between the pre-renal AKI and acute tubular necrosis, this is the best investigation that can lead us to the diagnosis. Okay, next question. Not a feature of CKD. I guess I have given you hints to this question already, and this is a PYQ. Which of them is not seen in a patient with CKD? Hyperparathyroidism, right? So in CKD, what happens? In CKD, there is increase in the phosphate levels because kidneys are the only way for elimination of phosphate. Increased phosphate activates FGF23. FGF23 inhibits bone mineralization. Second, there is decreased vitamin D synthesis, active form of vitamin D, and because of that calcium levels decrease, and the decreased calcium level body tries to correct by increasing parathyroid hormone. So hyperparathyroidism is true, it happens, right? What type of hyperparathyroidism? Secondary hyperparathyroidism, right? Now the parathyroid will clear the calcium from the bone. FGF23 will inhibit the mineralization. So obviously we do develop osteomalacia. So that is also true. Okay. Now do we see hyperthyroidism in patients with CKD? The answer is no. There is no direct relationship between the thyroid gland and CKD. So this is false. It is not a feature of CKD. Decrease in 125 dihydroxyvitamin D3? Yes, because kidney is required for the conversion of the unihydroxy vitamin D3 to dihydroxyvitamin D3. So if that doesn't happen, if there is a kidney damage. So the answer for this question would be option C. Hyperthyroidism is not seen in patients with CKD. Okay. Next, all are features of CKD except hyperphosphatemia, hypophosphatemia, hyperkalemia, hypokalemia. I think I have given you the hints on this question also. Typically speaking, we know that hyperphosphatemia happens in patients with CKD. We also know that hyperkalemia happens in patients with CKD. But some conditions, especially the renal tubular injury, renal tubular acidosis type of conditions, right? In some cases, you can have hypokalemia. But hypophosphatemia is never known to occur in patients with CKD until and unless our treatment, like by giving phosphate binders and all, it can cause hypophosphatemia. But directly, CKD will never cause hypophosphatemia. So what should be the answer here? Option B should be the answer. Hypophosphatemia is not a feature of CKD. It can be a complication of treatment of CKD. If the phosphate is high, to bring it down, I will put a too stringent restriction in the phosphate intake and I will give too high doses of sevelamer, which is a phosphate binder. Then patient's phosphate level can come down, but directly not because of the CKD. So option B would be the answer for this question. Okay, next. Dementia in CKD patient on long-term hemodialysis can be due to. I think we have discussed this point even when we were talking about Alzheimer's disease. In fact, we got to know that there is a connection between Alzheimer's disease and this particular toxin, because of our exposure or understanding of CKD. Like we saw plenty of CKD patients were developing faster dementia in comparison to general population, right? The answer is option B. Aluminium toxicity has been implicated in pathogenesis of Alzheimer's disease, and previous generation of dialysis machines used to have very high amount of aluminium in the dialysate fluid, and that aluminium exposure was the reason for them developing dementia. In the modern day dialysis machines, we do not use albumin because we have understood their cause. Okay, next question. Most common complication of hemodialysis. When we start doing hemodialysis, right? Hemodialysis also comes with its set of complications. Basically, how hemodialysis operates, we connect the patient's vein or a fistula or a dialysis cannula to a machine, right? One port will drag the blood out of the body, will make it run through the machine where the dialysis happens or the filtration process happens, and the filtered blood comes back to the patient's body through another cannula, right? Now at any given point of time, right, almost 500 to 800 ml of patient's blood will be outside the patient's body in the machine and in the circuit, and it is not in the patient's circulation. So effectively speaking, dialysis is inducing a short period of hypovolemia. And what hypovolemia can lead to what complication? Obviously hypotension. So option B would be the answer for this question. Most common complication is hypotension. Okay. Now last question for the day. Identify the KDIGO stage of CKD. eGFR is given and urine albumin is given. eGFR and urine albumin, right? So I've already discussed and I've already told you that you must remember this KDIGO staging of the acute kidney injury as well as CKD, right? So eGFR of the patient is 55. So here according to stage, where should it fit? 55 fits into 3A, right? And what is the urine albumin? 180 milligrams per day, right? So 180 milligrams fits into A2, right? 55, that is 3A, and 180 fits into A2. 3A, A2. 3A, A2 would be the patient's stage, right? So let us look at the options. Or let me also confirm whether eGFR is 55, so that fits into 3A, and urine albumin fits into A2, right? So do I have an appropriate correct answer here? No, right? So it should fit into G 3A A2, right? G 3A A2, that would be the answer. So ideally speaking, I should have an option E and none of the above, making none of the above as the correct answer. Okay, so guys, I want you to remember the AKI definition, AKI KDIGO staging, refill criteria, and the KDIGO staging of the CKD. Then mineral bone density related image based questions, that is Rugger-Jersey spine and the Brown tumor image. Then I want you to remember the few MCQ PYQ points that we have discussed, and the cast. Almost every alternate exam there is one question coming from the cast, right? So before I wind up for today, just a quick summary of all these staging, because I'm expecting one question this time. So staging wise, acute kidney injury is defined as serum creat rise by more than 0.5 milligrams per deciliter within 48 hours, or by 50% within 1 week, or urine output less than 0.5 ml per kg per hour for 6 hours or more. That is how we define the case as acute kidney injury. Stage wise, the staging of AKI according to KDIGO can take into urine output or creatinine as a criteria, and if both criteria are applicable, whichever puts the patient in higher stage, that should be taken. Okay. Now creatinine wise, creatinine 1.5 to 1.9 times the previous value, that is stage 1, right? Stage 2 is 2 to 2.9 times the previous value, that is stage 2. Stage 3 is 3 times or more than that the previous value. Any value more than 4, even if the previous value was like just 3 or something, it will be automatically considered as stage 3. Any patient initiated on dialysis will also considered as stage 3. In terms of urine output, normal urine output is 0.5 ml per kg per hour. If it is less than that for 6 to 12 hours, it will be stage 1. For more than 12 hours, if the urine output is low, it will be stage 2. And if urine output is lesser than 0.3 ml per kg per hour for 24 hours or more, it will be stage 3. Or if the patient has anuria for 12 hours, that will also be stage 3. Okay, then we have this referral criteria or staging. That is pretty easy to remember, right? So stage 1 is risk, stage 2 is injury, stage 3 is failure. Only thing extra we need to know is when do you call it as loss and when do you call it as end stage kidney disease. So when kidney functions are altered for more than 4 weeks, it is loss. When they are altered for more than 3 months, it is called as end stage kidney disease. Okay, then we had this KDIGO staging of the CKD, right? So where we have two numbers, the GFR number and the proteinuria number. GFR number, stage 1 is when GFR is 90 or higher, which is actually normal. Stage 2 is when 60 to 89. Stage 3 is divided into 3A and 3B. 45 to 59 will be stage 3A. So in the question, the GFR was 55, that becomes stage 3A. Stage 3B is when 30 to 44. When it is less than 30, it is stage 4. When it is less than 15, it is stage 5. Any patient started on dialysis is also stage 5. Proteinuria wise, normal protein levels in the urine is less than 30 milligrams per deciliter. That will be counted as A1. 30 to 300 is A2 and more than 300 is A3, right? Okay, so guys, with this I am signing off for today. Tomorrow we will concentrate on extremely high yield table scoring system based questions. So we will address scores like ABCD2, CHAD-VASC, Cockcroft-Gault formula, then serum osmolality calculation. So there are some 10-12 basic concepts that we will address tomorrow. Hopefully we will be able to get one question from that. So with this I am signing off, guys. I will share the PDF on the Telegram in another few minutes. Thank you all. Thank you. Have a good night.